Hi, everyone. Thank you for joining us today. Tonight's webinar will be given by Dr. Alan Hilibrand, one of our spine surgeons here at Rothman Orthopaedics. Dr. Hilibrand sees patients in our Ben Salem and Marlton offices. I know he has a great presentation for us tonight. If you have any questions during the presentation, please feel free to enter them in the Q&A box at the bottom of your screen, and the Dr. Hilibrand will take time at the end to answer as many as he can. So you can take it from here, Dr. Hilibrand.
Thank you, Natalie, and welcome. Thanks for coming and joining us tonight. So tonight I'm going to talk about a few different ways that we treat problems in the neck or the cervical spine when they end up needing surgery. And I'm going to give you a little bit of a review first about cervical spine problems and how we do or don't need to treat some of those. So just by way of background, if I can get this to advance. So I grew up in Cherry Hill and was a graduate of Cherry Hill High School East a long time ago, and via MIT, Yale Medical School, University of Michigan, and Case Western Reserve University, I came around and back to Cherry Hill and back to Philadelphia back in 1998 to be one of the first people to start the Rothman practice in New Jersey. And I currently see patients, as Natalie said, in Marlton and in Ben Salem in Pennsylvania. So when we talk about the spine, let's give some general information to you. So today we'll really be talking about the cervical spine, which is the top of the spinal column. There's also the mid-back or thoracic spine, and then there's the low back or the lumbar spine. We're talking about the cervical tonight. And we're going to talk about first some of the problems that patients sometimes develop that might need surgery that are specific to the neck, the non-operative treatments that often make people better. And then when you need cervical spine surgery on the neck, what are the traditional surgeries, meaning the fusion operations, the newer motion-sparing options that are available, and then how to choose which is the right operation for you. So the first potential surgical issue is the problem of pain that radiates down the arm. We call this cervical radiculopathy, radiating pain from the neck, cervical, down the arm. And it usually follows the path of the spinal nerve that's being compressed. And the sensation usually follows a specific pattern, and the doctors will look at or have memorized this kind of a map of where the nerves go down the arm. And usually, while never exact, as physicians, we think about symptoms that go to the thumb being the C6 nerve, the middle finger being C7, and the little finger being C8. Now, this is one problem that can cause cervical radiculopathy. This is a herniated disc. This is a drawing of a herniated disc that compresses the exiting spinal nerve root, which comes off of the spinal cord. And this is a cross section looking down from above at the cervical spine. That corresponds to a picture that you might see your surgeon show, which has this disc herniation on the other side, compressing the nerve that comes out of the spinal cord. Now, generally, people who have cervical radiculopathy get better in 6 to 12 weeks. And so surgical treatment is usually reserved for people when the non-operative treatment fails, or maybe a little earlier if they have progressive weakness associated with it, like if they can't lift their arm. That's usually a problem that's very disabling. But overall, about 70% of people who get cervical radiculopathy are going to get better with non-operative treatment. So the medical management is the typical ones for a lot of orthopedic problems: non-steroidal anti-inflammatories, acetaminophen or Tylenol. Sometimes when it's a real hot nerve, very painful, we'll try oral steroids or what we call a prednisone taper. Muscle relaxants are sometimes indicated. And then there's also activity modifications. So basically, we say what the doctors always say: if it hurts, don't do it. So usually, if it doesn't bother you, you can do it. But we usually advocate for physical therapy, which usually consists of some positional exercises that reduce the pain, strengthening of the neck and the muscles that connect the neck to the upper back, and then stretching sometimes of the cervical spine, or what we call cervical traction. Now, another potential surgical problem is what we call myelopathy from spinal cord compression. So myelopathy, technically speaking, means myelopathy, spinal cord disease. And it's really the most common cause of problems with balance in older Americans. It has a fairly classic clinical presentation with problems with balance and walking, and also often associated loss of dexterity and coordination in the hands. Sometimes it's actually silent, meaning people don't notice it because they have spinal stenosis in the low back and they have a lot of leg pain, and they don't realize that they're weak and off balance as well, and that might be coming from something different. Now, when we have patients with cervical myelopathy, we usually refer them for imaging because that's a little worrisome problem when there's functional things going on. And so this is a side view of an MRI of the neck, and you see that there is pressure on the spinal cord. And that's the kind of thing that can cause cervical myelopathy. Now, when you take a cross-sectional picture, normally the spinal cord itself looks oval, like in this picture. But when there's myelopathy, usually there's also compression flattening the cord, as you see in the middle picture. Sometimes there's generalized narrowing of the spinal cord and canal, as you see here, where there are several levels where there's no spinal fluid around the spinal cord like there is above and below on this MRI. So, non-operative management. Well, it's not clear whether really non-operative management is appropriate if people truly have myelopathy or spinal cord disease. That means they need to have spinal cord compression and symptoms of balance coordination. Sometimes bowel and bladder issues can also arise. And the reason it's unclear is because generally, from the studies that were done back in the 50s, when no one really understood much of anything, but they could get a myelogram and see that there was pressure on the spinal cord, they knew that once people had that, they tended to get worse over time. About 70% progress over time. Now, for patients who really are surgery averse, or if they have very early myelopathy and they want to follow it a little bit because it seems to be stable, then you could advocate for physical therapy, braces for the neck, or activity restriction, but there's really not much evidence that that's helpful. So again, why not non-operative if it's myelopathy? Well, usually there's damage to the spinal cord itself. And unlike a spinal nerve, which is outside of the spinal cord nerves can't regenerate. They're like the brain cells, like if you drink a lot and you lose brain cells, they can't grow back. A pinched nerve in the arm can regenerate, so it's different. Now, early in the disease, when the spinal cord has not had very much impairment or loss of nerves, it can rewire itself to some extent. So really the prognosis in terms of how well people do with surgery for myelopathy depends on how long they've had the problem. If they're healthy and young, or older and not healthy, meaning the spinal cord's not as resilient, and if there's damage to the spinal cord itself. So let's go back and look at the picture I showed you before. This MRI shows something we call myelomalacia. That's a white spot in the spinal cord where there's an area of nerves that have been knocked off. Now, this picture I also showed you where there's a narrow spinal canal, but there's no white signal change. But that patient also had myelopathy. So it's not necessary to have the white spot if there are functional issues. It's still myelopathy. So, okay, so sometimes, as I said, neck surgery is necessary. So what are the options? So in the cervical spine, there's really two ways to approach it. You can go in the front, the anterior approach, or you can go in the back, a posterior approach. Now, the anterior approach, there's two common operations, and this is 99% of anything that's going to be recommended. The classic traditional operation is an anterior, going from the front, cervical, referring to the neck, decompression or discectomy, and fusion. And that's been done for 50 or 60 years with good success. A newer option is a disc replacement that is also done from the front and is similar to the ACDF, except we put two moving parts in instead of a bone graft and a plate that fuses together. Now, in the back of the neck, the traditional workhorse has been laminectomy and usually nowadays with fusion. Again, stabilizing, but a laminoplasty in the neck or plastic surgery of the lamina is another option. And number two in each of these columns are motion sparing procedures, and we'll talk about them a little bit more. So, ACDF has been the gold standard, as we say, for cervical radiculopathy. And this paper was the first really seminal paper to describe long-term outcomes of this operation to show that more than 90% of people got rid of the arm pain and they didn't really get worse over time. And we still called this the gold standard even today. And why is it so great? Well, it's not just going in and taking pressure off the spinal cord, but there's some parts of the spine that are hard to access in the front or back. One of them is the nerve tunnels. So here you see where the arrows are. Those are the nerve tunnels where the nerve comes off the spinal cord. And with an ACDF, with a solid ACDF, when you take away the motion, it removes the motion that's causing arthritis. I'm sorry, my light came out here. And we take away the motion that causes the arthritis, the spurs actually go away, as you see in this 2-year follow-up from that x-ray. So if that's so good, why disc replacement? Why do we even need that operation? Well, one reason is because we think that with a fusion at one level, you can get disease at another level or an adjacent segment, meaning maybe the fusion causes more force at another level, and that causes new problems to occur. So I wrote up 25 years ago a series of over 400 patients following ACDF some of which who developed new problems at adjacent levels. And we noted that about 3% of the patients who had undergone an ACDF per year would get new problems at another level. And so if we do a survivorship analysis, which is kind of seeing whether the ACDF survives without needing another operation, we found that about 75% of the patients would still not need another operation at 10 years, meaning 25% would not survive and go on to have adjacent segment disease. Now, that counts both surgical and non-surgical patients. So that means with about 50% getting better with non-operative care, the adjacent segment disease rate really, in terms of needing surgery, was about 15%. Well, nevertheless, after that study was published, industry produced a number of moving devices that we call a disc replacement. And there are 6 examples here of prospective randomized trials that were funded by industry to identify implants that are successful in addressing cervical radiculopathy without doing a fusion. And the outcomes for those are really quite good when we look at adjacent segment reoperation, but also same segment. So sometimes if you do an ACDF, the bone graft doesn't heal, and you need to do another operation at that level to get it to heal. That's what we call same segment reoperation. So in this study, using the Mobi-C disc replacement device at 2 levels, because you can do it at 1 or 2 levels, at 7-year follow-up, there were about half as many same segment reoperations for the disc replacement, or CDR, than the ACDF, or anterior cervical discectomy and fusion. And the adjacent segment reoperation rate was less than half for disc replacement versus ACDF. This is another study of another 2-level disc replacement device, the Prestige device at 10-year follow-up. And in this study, the disc replacement was statistically superior to the ACDF, to the fusion, in neck disability, pain, and neurologic outcomes. And again, there were a lot fewer same segment surgeries and half as many adjacent segment level surgeries. So why shouldn't everyone have a disc replacement? Well, one of the problems is people have a lot of arthritis. And really, if you're doing a disc on a properly indicated situation, Patients should have about normal disc height. And really, this operation is a home run in patients who have a disc herniation and no instability. For myelopathy, sometimes it's indicated if there's only one or two levels of spinal cord compression, and if the spinal cord compression is at the disc space itself. So usually that's from a disc herniation or an old disc that's become a spur, but not a lot when they have a lot of arthritic spurs. So here's a picture again. So this is that cross section we see, and the arrow, the red arrow, is pointing to a herniated disc. And you see that it is compressing the side of the spinal cord, and you don't even see the exiting nerve that's also compressing. But this patient has radiculopathy, and this is actually a good indication for a disc replacement. And that's what it looks like if you do it at a couple levels. Now, on the other hand, this patient's a little different. This patient, the same kind of cross section, but you see the arrows point to the problem in terms of the nerve compression, which is not right in the canal itself on the spinal cord, but it's off to the side. And you can get some of that out going in the front, but you have to take a lot of bone away. And so when you have to resect a lot of bony spurs, usually that's better for an ACDF. And it looks like that. That's what that kind of an operation looks like. So we'll come back to that at the end about disc replacement. I'm happy to answer questions. But now let's talk about the back of the neck. So the cervical laminectomy and fusion, as I mentioned, is a very versatile approach. It's great for severe arthritis. If there's an unstable spine, what we call a spondylolisthesis, and it gets the best decompression available because you actually remove the lamina. So this is looking at the back of the neck, and the lamina here has been taken away, so the spinal cord can float back into that space. And it looks like this in cross section. So you see this bone is gone here where there's a laminectomy defect. So this is an example of severe neck arthritis. I showed you MRIs before where you saw that there was some fluid around the spinal cord. Here, there's not just no fluid around the spinal cord, but there's bright signal all the way up and down the spinal cord. And look at how arthritic that looks. These are all spurs compressing the spinal cord, and all the cross-sectional pictures show there's bone in the spinal canal. This patient should not have anything but a laminectomy and fusion, which the patient ended up having. Now, it's a great operation, but it's a lot of surgery. It's more surgery time, it's a longer length of stay, and most patients have to stay in a hard collar for at least a month. There's also the risks, infection. A lot of people can get temporary shoulder weakness. They get stiff, they get some neck pain, and actually it has a lot of adjacent segment disease associated with it, meaning you fuse a number of levels, but then the ones above and below can also still break down. So are there other options? Well, there's laminoplasty. So the laminoplasty is work on the back of the neck, but in this case, and on the left-hand slide, this is that cross section. I've turned it upside down because we're working in the back now. We take a little wedge of bone where the blue triangle is, and then we open up the spinal canal by hinging open on that, and then put a graft and plate, as you see on the side here, and that gives you more room for the spinal cord. And as you see on the right-hand picture, you do it at a few levels and let the spinal cord really open up the space, and yet in the same time, you keep all that bone in the back for the muscle to heal down to. The laminoplasty is kind of an interesting operation. I did the first one early in practice, and this is an example how the lamina gets hinged open. Back then, the standard of care was to use a heavy suture to hold the lamina open, and it healed, but there was some neck pain associated with it, and I really didn't do very many of them. More recently, we've developed rigid plates and grafts and techniques that preserve certain attachments so that we can preserve the motion. There's very little pain after surgery, and the healing of the muscles is much better, especially in comparison with a laminectomy and fusion. So here's an example, and now you've gotten used to looking at these, but I'll still kind of describe it. So this is a side view of the spinal cord, and you see it's narrow and a little bit compressed at a number of different levels. Well, after the laminoplasty, that same picture looks like this, and you see there's a lot of room around the spinal cord. So even it's not a laminectomy alone, it's just a laminoplasty, is a lot of room. in the cross-sectional picture, you see the spinal cord here is really compressed. And in follow-up, that looks like this with room around the spinal cord. So, well, when is a laminoplasty indicated? So from the perspective of a patient, well, it's kind of a good thing to have. It's less invasive, it's motion sparing, it's plastic surgery, clamshell opening of the lamina, and there aren't a lot of complications. And so there's less impact on the patient. Shorter surgery, sometimes no collar, sometimes a soft collar for a couple weeks. Wow, that's a great operation. Who's a candidate for it? So, from the surgeon's perspective, from my perspective, someone who has predominantly myelopathy, I never do this for radiculopathy, a narrow spinal canal in the neck, because that's where I really do the best work, making room for the spinal cord by going in the back. Normal curvature of the neck. And the problem is when it's not normal, when someone has a neck that's pitching forward, that person cannot have a laminoplasty. Sometimes they can't even have a laminectomy infusion either. When there's compression that goes into the thoracic spine, so some of those patients that have severe arthritis have that goes all the way down the thoracic spine, the upper back. You can't do laminoplasty down there. And when there's a lot of instability, we prefer to do a fusion than a laminoplasty, and severe arthritis, as I mentioned before. So not clinical limitations are people who have neck pain, because actually it's not indicated for neck pain, but recent studies have shown that people with a laminoplasty tend to have less neck pain than people with a laminectomy infusion. And they heal much better and the wounds look much better. Also, it's fine to do a laminoplasty if there's an instability at an adjacent level, because there's less stress on the adjacent level when you do a laminoplasty versus doing a fusion. If you do a fusion, you got to really include that next level. And what is the evidence for laminoplasty? Again, this is not the point of the talk to go into a lot of detail about clinical studies, but I would cite one recent one that we were a part of at the Patient-Centered Outcomes Research Institute of NIH. And this was a grant, multi-center trial, looking at ACDF or a laminectomy fusion or a laminoplasty. And the surgeon and patient had to decide what was the right approach. And other surgeons like me would then look at the studies and say, well, could they have any of the three? Yes, they could. Then they're okay to be in the study. And they followed the patients for more than 4 years. And the outcomes were really remarkable. Now, SF36 PCS is a complicated term, but basically it says, how's your physical function? And the better the physical function is, the higher the score is. And on this graph, that gray line is the function of the laminoplasty patients. The green line, the blue line is an ACDF, and a red line is a cervical laminectomy fusion. And you see that the gray line starts at about the same place as the blue line, but it got a lot better and stayed a lot better out to 4 years. So it's a superior clinical outcome versus ACDF or cervical laminectomy infusion. As a secondary outcome, laminoplasty also had fewer complications. So just to wrap this up, and then I'm going to answer any questions you have. Disc replacement versus ACDF. How do you make a decision? Well, I think that there's a lot of enthusiasm for disc replacement. A lot of it is driven by marketing to patients and surgeons who say you got to refuse to fuse. And I think there is a lot of evidence now to suggest that disc replacement is a good option for a lot of patients, but not all. Some patients aren't candidates for a cervical disc replacement. And some surgeons are still reluctant to adopt this, but it is a good operation. And how about laminoplasty versus laminectomy infusion? Well, to summarize, laminoplasty is less surgery and less invasive. It is motion sparing because you don't fuse anything, and the motion's pretty good. It's just about as good as before surgery, maybe a little stiffness from the surgery itself. There is some higher surgeon reluctance. It's a little bit of a technically fussy procedure, unless you do a lot of them. So there is a learning curve to this type of an operation. And I would also say that the overlap is really not precise for this problem either, because if this is the whole world of patients who have arthritis in the neck and stenosis and are appropriate to have an operation from the back of the neck, probably this many are laminoplasty candidates, meaning all the ones in purple still probably need a laminectomy infusion. So thank you very much. I appreciate your attention, and I'm happy to answer what are probably a few questions you have about this talk. Natalie will help.
Thanks. Thanks, Dr. Hillebrand. Yeah, some questions coming in. Great presentation. Okay, so I'll go through them. First question. In the long term, how significant is the difference in neck mobility or pain from motion sparing surgery versus fusion approaches?
Well, it depends what we're talking about. If we're talking about an ACDF going in the front, the neck motion difference is very small unless you get to a 3 or 4 level fusion. And even then, we showed clinically, we did a study 20 years ago using some biomechanical apparatus at Drexel University to show that actually 2 years after surgery, the 3 and 4 level ACDFs had almost as much motion as they had before surgery. But obviously, with the disc replacement, it's been shown that the motion is fully preserved. Now, as you go down further in time, some disc replacements do tend to become stiff and act like a fusion. So those people will end up the same place as an ACDF. With laminectomy and fusion versus laminoplasty, there is a larger impact because usually a laminectomy and fusion is done across 4 or more levels. And so in that case, you do have real stiffness and tendency to posture forward a little bit, even though the curvature of the neck is a little bit better.
Thank you. This person said, I've had a fusion of C2 to C7. Now there is an issue with C1. I am adverse to another fusion. I won't be able to turn my head and possibly will not be able to drive. Are there any options at that level other than a fusion?
Unfortunately, that's a difficult problem. It's a pretty rare problem, so I feel very badly for you because it's not a common thing to have. But the C1-2 arthritis problem, which is, I think, what you're describing, is almost more of a congenital hereditary thing. It's probably not caused by the fusion, but the fact that you may have had a lot of arthritis to begin with throughout the neck. And that's one of the places that arthritis can continue to develop when the other levels are fused and they are stable. So I am sorry to hear that, but really there's no good options that I'm aware of that have any scientific support to them other than stabilizing that one level. I would not recommend stabilizing to the base of the skull as well, because that would make it even stiffer.
Thank you. Someone said, please explain radiculopathy and myelopathy so that they can understand the distinction between them. I know you touched on that, but
Okay, so no, they are complicated concepts, and I deal with it every day. Let me try to be straightforward about it. When there is, like for example, a radiculopathy, it's best to think about radiculopathy, although it's not always caused by a disc herniation. It's usually more commonly from a disc that herniates, pinches the nerve, and rather than having symptoms that affect a lot of different nerves with coordination and dexterity, it's only affecting that one nerve that's being pinched, like that picture I showed at the beginning, that drawing with a soft fragment going off to the side. That one nerve is what's causing the problem, and usually it's more pain. Maybe it's numbness, weakness in a specific group. With myelopathy, that disc would be pushing on the spinal cord itself, and the spinal cord compression affects many nerves, and it affects the ability of those nerves to talk to each other. So when you do this with your hand and you open a jar, or you're walking one foot in front of the other on a balance beam, it's not only your brain that's working, the spinal cord itself is taking feedback and communicating to the nerves that go up to the brain and then back down from the brain and trying to make sure that you stay on track. And when there's a problem with that communication because there's damaged nerves, it affects that function. So while you could have weakness in your hand that affects coordination from a pinched nerve, it's more commonly going to be clumsiness and weakness in the hand from the spinal cord compression. That's kind of a simple way, but again, myelopathy, spinal cord doesn't work right, and you have coordinated movements that are affected. Pinched nerve, more discrete, 1 or 2 muscle groups that are weak, or one part of the arm that's painful.
thank you. What is the expected loss of motion for an ACDF of C4, 5, and 6?
This should be almost none. I mean, the actual range of motion at each level is about 5 degrees, and a 5 or 10 degree loss of motion is not noticeable by patients, in part because usually they don't, when we did our study, we realized they don't actually usually lose the motion. What happens is when we fuse the people, they don't move at those levels. But the upper cervical region, we talked about this before with that prior patient, the skull, C1, which is a ring, and C2, which is a process that goes up through the ring, allows half of all of the motion in the neck in a normal person. So when people get arthritis that's really bad in the lower neck, the upper cervical spine, if you're not arthritic there, can handle half of the normal motion, and people sometimes don't really notice it. But when you fuse two levels, like we're talking about here, most of that motion, the 10 degrees that you lose of motion, goes to the cervical spine where it moves, upper cervical, where it moves a little more. And so usually the patients don't notice it. Now, again, more levels, maybe a little more noticeable.
Right, thank you. Lots of great questions coming in. Um, recently, so this person said, recently I have read about endoscopic microdiscectomy as an option to address pinched nerves in the cervical spine. If you're familiar with this, what is your opinion of this procedure?
So there are two ways to do it. One is going in the front, and going in the front, you go right where the disc herniation is and kind of pull it out. It is technically challenging and it has some risks because you go by the esophagus and a large artery that's in the neck, actually a couple large arteries, and those structures are at risk. The other problem, and that, so if you train enough and do enough, you might get good enough to do it. It's a tough operation. But the problem with that operation is in the neck, where there's a lot of load going through the disc itself, when you take part of the disc away to do that, and you're not just taking the piece out of the canal, you usually have to go through the disc space itself to do it, you're disrupting the disc further. And that, although we don't have long-term follow-up studies to see, we believe from a lot of really just anecdotal information, that's the best we have, that over time those discs degenerate and then often need additional surgery. In the low back, different. I think in the low back, that's a better indication.
Thank you. Are any of the surgeries you presented on good for simply neck pain without arm pain, or is surgery usually not indicated for neck pain only?
That's a tough problem. Neck pain is something that generally we can't help with surgery, although there are many people who have pinched nerve pain. I had on my slide that sometimes people have a lot of neck pain. In fact, sometimes the neck pain over time becomes worse than the arm pain. And those people, someone may have initially 80% arm pain, 20% neck pain. And they wait and they wait and they wait, do therapy, and it's getting better, but the arm pain's getting better, but the neck's still there. Yeah, the neck's getting worse, the neck's getting worse. Suddenly they say, I'm going to have surgery. I can't take it. Now it's 80% neck pain, 20% arm pain. So if you go back and you reconstruct the history and you realize that it's the pinched nerve that started it, and that's really sort of still at the base of it, but it's mostly neck pain now, those people I think can do very well. But people who have strictly just neck pain, unless there's a postural deformity, if they're pitched forward, or they have a fracture or infection of the disc space, really we recommend non-operative treatment for those.
Great, thank you. Is there an age cutoff for any of these surgeries?
Um, you're going to usually you're not going to do this in an adolescent because they don't usually have even disc herniations until they're after about 15 or 16 years old. And as far as elderly, there's no real strict age cutoff. There is some evidence that people over 80 don't do as well from myelopathy surgery, meaning there's not really much in the way of recovery with the surgery. It's just to stop people from getting worse. And we tell everyone myelopathy surgery stops people from getting worse. And if you're younger than 80 and you haven't had it that long, you might have some pretty good improvement. But there's no strict age cutoff.
Great. Are you an advocate for of neck supports or braces to lessen disc pressure and keep correct neck alignment?
The theory behind that makes a lot of sense because it definitely lessens the pressure on the discs and helps with pain. The problem is you can't live your life in a brace, and at some point you're going to take it off. And when you're wearing the brace, it works well, but the muscles are getting weaker. And that's the key to both not just neck pain treatment, but also back pain treatment. The stronger the muscles are, especially the muscles that connect the head down to the shoulders and the upper back, the stronger those muscles are, the more they control motion of the head on the shoulders, and the more they're sharing the load of the head on the shoulders, and there's less load on the spine. That's why it actually helps with worn out discs. And that's why when you wear a brace, like I'll put someone in a brace where they have an acute injury or acute pain, but I wouldn't keep them in it for more than a week or two. After surgery, we keep them in braces maybe for a month, but even that's not everyone. And it's really because we don't want them to get too weak. And that's the biggest problem we have. That weakness is caused by prolonged bracing, even though it is comfortable and helpful.
Thank you. What tests and what medical specialist should one see to determine treatment?
Well, I think that usually the primary care physician is a good place to start if you have a relationship with him or her. And they're going to be able to start by sorting out and getting you the initial treatment usually. But if they're not, after the initial treatment, if you're not starting to get better after a few weeks, it's really appropriate to see someone who specializes in treatment of spinal disorders. Um, there can be, in our practice, we have a broad range of people, both surgeons, non-surgeons, um, and also advanced medical providers who work alongside those providers. And so there's a whole big group of people to get you in quickly and get you started. But most of the time, whether it's a surgeon or non-surgeon, it's best to have someone who's familiar with treating, and I would say exclusively treating neck and back problems. And usually they're going to have you do non-operative treatment first, and then if it's not better, have you see one of the spine surgeons.
Thank you. Can you do a disc replacement if you already have had a fusion on other levels, new segments?
Yes, you can. There's certain things that go into making that decision. I've done that several times, and there's not been any problems in long-term follow-up with those patients. I see everyone for 2 years after surgery to know that they're doing okay, sometimes longer. And those people I follow long-term. But there are some things, there's certain implants, you need a more stable implant. So I didn't go into the details about different discs and how stable or mobile they are. But, generally I like a disc implant that moves a lot because we're trying to restore motion. But in some cases like that, where there's a fusion at an adjacent level, I'd have a relatively stiffer or less mobile implant.
All right, thank you. So a lot of great compliments, excellent presentation, very knowledgeable, and thanking you for this. Next question, how would one find a surgeon for lamnioplasty if it isn't as commonly performed?
um, Well, I think that I think that it's important to start with a knowledgeable provider that performs spine surgery, in general, and performs cervical spine surgery in general, and then most of them would have that in their armamentarium, and you could discuss with them, if they say you need a laminectomy infusion, say, okay, well, could you have a laminoplasty? And I'd be quite frank with people. They have severe arthritis, they have instability, you can't have that. If they don't, that's a good option. Here are the benefits, here's the drawbacks. Do you want to go that way? And I think that, I think that generally at larger centers like ours and academic medical centers like ours, you're going to see much more of this kind of an operation. I think it's less common in the community, but I think many people do it and do it very well. But it's hard. I mean, I don't know if you could search online and you'd pull my name up and say, oh, he does laminoplasty. Let's go see him. And my partners also do that. So it's a little hard. I don't have a better answer just to accept to see someone who does a lot of cervical spine surgery.
Thank you. What are your opinions on targeted steroid injections?
I think they're very good for a really hot nerve that's inflamed, to really quiet it down. there's limited evidence as to whether it has long-term benefit. In the low back, it actually can avoid surgery in some cases, but in the neck, it's more used as a diagnostic tool. So there's something called a selective nerve root injection, where they inject the steroid actually towards the front and they put it along the path of the nerve. And it bathes the nerve with the steroid and at least gives people temporary relief if that's where the problem's coming from. And I think that's a very good indication when you have a patient who has a radiculopathy, but we're not quite sure which level it is. And we see that one level's narrow and we think it's that level, but we're not sure. You might want to try that injection. There's some studies that show that if you get a good response from that injection, there's a 90% chance that addressing that with surgery is going to make the problem go away.
Right, thank you. When is it indicated to see a neurosurgeon versus an orthopedic surgeon?
Well, I think the important question is, seeing a spine surgeon. And uh, both orthopedic surgeons and neurosurgeons now, if they are serious about doing a lot of spine surgery, will do a spine fellowship. When I went into practice, that was not the case, and it was a complicated topic because a lot of orthopedics did this part of the spine, and neurosurgery did that part of the spine. But now people who are fellowship trained, like all the spine surgeons here at Rothman, they take on both. The limit as far as the things that I would not do because I am orthopedic surgery trained is tumors that are within the spinal cord itself. I would always consult one of my neurosurgery colleagues and work with them to take that off.
Thank you. I think we have a PT who asked a couple questions, and his one question was, do you have a specific protocol for rehab following surgery?
I think so. I think that with an ACDF, we don't cut any muscle. And I think that most patients really don't need rehabilitation except coming out of the collar and moving the neck. And about 10% of the time, they do have some stiffness, especially if there's been some distraction of the facets posteriorly. But I really leave it to the therapist in those situations to evaluate the patient, identify kind of the pain source, and focus besides isometrics and cervical thoracic stabilization exercises to do some modalities to the specific indicated areas. Um, for a patient who has who has a posterior cervical operation, I usually have them do therapy to work on just getting their motion back and working on posture. And postural and extensor training is the most important with any neck operation, but that's my focus more normally.
Thank you. Is there any indication for a facet fusion at one level if the facet arthritis is really bad, but not spinal cord or nerve root compression? Even if there is not radicular pain, but neck pain is significant despite physical therapy and failed relief with ablation to the facet.
So I have never personally done that. It goes into the source of kind of neck pain where I have a lot of patients who get better with injections into the facet joints, and I usually recommend an ablation of those facets if that's the case. And we have a large team of non-operative spine specialists who are experts at doing that procedure, a facet ablation, and I usually send them to my partners. And I've never really had them come back and say, all right, now do a fusion at that level. I've seen people who have bad arthritis front and back of the spine that involves the facet joints, and that might lead me in some cases to say maybe the fusion they need needs to be in the front and the back instead of just the front if they have like a disc herniation or big spurs. But that's about it. We really don't fuse facets for facet arthritis because it's hard to really get that to be successful. And again, you fuse that level in the back, you usually affect the facets above and below, and they're usually arthritic also. So it's a cascade. You do one surgery, then you do another surgery, then you come back, you do another surgery. So you don't really want to go down that road.
Thanks, Dr. Hilibrand. Next question. You mentioned people with their neck leaning forward, which this person has. When they raise their head to the correct level for a short amount of time, their right arm and hand become numb. Which type of surgery would you recommend for this?
Well, that can be from a couple different things. That can be from a herniated disc, but it can also be from a narrow spinal canal. And it really depends. I'm happy to see that person and evaluate them in their imaging and make a recommendation, but I can't really say anything with that, even though that's a very significant issue when people have that. That's a little bit suggestive of myelopathy. So I would say they should definitely see a spine surgeon. I'm happy to see them and evaluate all their films and evaluate them, examine them, and kind of come to some suggestions for them.
Right. Okay. Thank you. When is an EMG helpful to have?
Ah, it's a good question. So EMGs are very good in a couple settings. One is if you really think it's coming from somewhere else, but it sounds and there's some arthritis in the neck, and you say, well, for example, if you have ulnar nerve compression at the elbow, you can have symptoms down the forearm. And that's a lot like people who have pinching of the C8 nerve. And that's one that I often ask for an EMG because if it's the ulnar nerve that's being compressed, they'll almost always see it on the EMG. Now, if the person doesn't have ulnar nerve problems and we want to diagnose a C8 radiculopathy, well, the EMG is not as good. It only sees it about 50% of the time. But if the EMG says it's cervical radiculopathy, we say it's very specific, meaning if it says radiculopathy, it's radiculopathy. If it's not radiculopathy and it's not something else, it could be radiculopathy, but it's not very sensitive at picking up radiculopathy. Another good example of that is people who have symptoms that go down the arm, but sometimes people just have symptoms in maybe the middle finger or the middle and ring, and you think maybe there's carpal tunnel. And that's a good thing because, again, an EMG is really good at diagnosing carpal tunnel. Not necessarily as good at C7 radiculopathy, but if it's not carpal tunnel, if it runs down the arm, it's probably C7 radiculopathy.
Thank you. What
I
is
know that's
your
a little technical for some people, but maybe that's a physician that asked that question. So,
Yeah, thank you. Dr. Hillebrand, what is your opinion on using gabapentin long term for pain management for cervical radiculopathy instead of surgery?
I think that being on any medicine is bad. I really am averse to taking medicines in any concerted long-term fashion, except for medical issues that really are important for general health. So, yes, spine pain is general health, but if faced with a question of whether someone would be on a long-term nerve agent versus having surgery in the setting of not much compression and good relief of the nerve agent, that's a tough call. But if there's any real compression of the nerve, I don't think that's a good idea to stay on the medicine because not only do you get more and more exposed to the side effects, and I could refer people to the article about a month ago in the Wall Street Journal about gabapentin, which is the most common of those medicines, but not only are there a lot of complications, but they kind of build over time. So, for example, I think that there's some recommendations that you need to see a physician at least once a year for refills if you're getting continuing refills on a medicine like gabapentin or the other one that's common is Lyrica. So they're very good to quiet down pain in the acute phase. And sometimes if there's some bothersome pain that's still there, especially post-surgical, when 90% of the problem's gone, but this 10% is still bugging the patient, that might be the only good alternative. But even then, we try to wean that down and off eventually over time.
Thank you. Would a patient with severe adult torticollis benefit from seeing someone at Rothman?
Yes, that's a problem that often requires surgery for correction, and there's it depends if it's true. If it's true torticollis, it's often related to a problem at the upper cervical spine between the C1 and C2 vertebra. So that's something that should be ruled out because that's something that not only can be fixed, but over time, if there's a deformity of that the spinal alignment, it becomes permanent. One of the problems is that when people have long-standing spine problems, especially deformity problems, pitching forward, things like that, when it's a long-term problem, it's very hard to fix because the spine really loves to go back where it was before you operate on it. So I can make the person like this, but unless I do stuff in the front and back of the neck, they're going to start doing that because that's where their head thinks they should be. That's just part of, the spine itself. Now, when it starts pitching forward, you can do stuff that doesn't involve as much surgery and be successful. But torticollis is one of those things where you really want to work that up with certain imaging modalities to find out what the problem is. And if it's purely muscular and no structural thing, you would not operate on it. But you should probably rule out the structural stuff first.
All right, thank you. I think we have time for a few more. Great questions. Um, is there anything that partially fused patients can do to avoid development of adjacent disc disease?
Well, if it's partially fused, meaning it's not fully solid, but it's mostly solid, that in a way is probably somewhat protective because there's still some motion. It's like a disc replacement. It still moves a little bit. So that actually might reduce it. But if you say partially fused, meaning one or two levels, what I tell everyone, whether it's front or back, keep the neck strong, strengthen those muscles, do those exercises. Well, you can't do resistance exercises every day, but every other day, do the resistance exercises. The other days you're not doing resistance exercises, do some stretches and really focus on maintaining good posture of the neck and keeping those muscles across the side of the neck and into the upper back and shoulders as strong as they can be. That's the way to avoid getting breakdown at other levels. That's the one thing people can do. Also, not smoking, because smoking is also associated with much more adjacent segment disease.
All right, thank you. You mentioned myomalacia. Can you talk a little bit more about what that is?
So, so myelo is spinal cord and malacia is like damage, disease. And so myelomalacia is seen on an MRI as usually a circular or oblong kind of white spot in the picture where there's fluid on the sides that is bright and the spinal cord in the middle is dark. And that can develop slowly over time or from an acute injury. So people with spinal cord injuries have a very big area usually of myelomalacia. People who have degenerative cervical myelopathy get it slowly over time. But what that white area reflects is basically fluid in the spinal cord that's forming or that has kind of developed where there are dead nerve cells. So that's like what we say, like, it's not just you could see some nerve loss on exam because they have abnormal reflexes and they can't put one foot in front of the other. It's like you can see on the MRI right there, there's damage to the spinal cord. So that's a problem that really you don't want to get to that point. If you have myelopathy and you start having the symptoms, that's why it really should be a surgical disease and not a non-operative treatment in most cases, especially if it's myelomalacia, but also to keep people from getting myelomalacia.
All right, thank you so much. I
I'm
think that's
sorry I'm
it.
getting a little in the weeds, but
No, it's
yeah,
okay.
I mean it is sort of a complicated topic, and I appreciate people's patience and understanding and following through on this.
Absolutely. They were really great questions. Your presentation was wonderful, Dr. Hillebrand. Um, thank you so much. Thank you everyone for attending. Couple questions about if this is will be recorded. We are recording this. We
Yep.
will be sending it out likely by the end of the week to everyone who joined tonight and anyone who couldn't make it on as well. Couple questions about how to get in touch with Dr. Hillebrand or make an appointment. You all have my email from the reminders about the webinar. Feel free to reach out to me directly, and I'm happy to assist with scheduling an appointment. If you have any further questions, you can also visit our website at rothmanortho.com. Also, our phone number is 800-321-9999. But again, I'm always happy to help assist, so you can reach out to me directly as well. Thanks so much, Dr. Hillebrand. Thank you, everyone.
Thank you very much. Thank you. I
Have
appreciate it.
a
Thanks for your time, guys. Have a
have
good
a
evening.
great night.
Thank you.